welcome to Pain in the Podcass, your place to find out everything you've ever wanted to know about pain. My name's Dr. Joseph Parsons, and I'm joined by the phenomenal Don Widgesoria and Dr. Joshua Craw. And today we're talking about pain in palliative care, part 1. Welcome in.
Hello and welcome to Pain in the Podcast, and today we'll be discussing pain in palliative care. I'm joined by Dr. Joseph Parsons and Dr. Joshua Craw, and my name is Don Widgesoria. Let's get into it. As always, let's start off with some facts about ourselves. Joshua, would you like to go first?
Sure, absolutely. So, the fact about me for this week is I seem to be on an 11-month cycle for dysentery. Genuinely, when we're recording this, a couple of days before we started recording it, I got horrific, I'll say gastroenteritis. And I messaged in the group chat, I was like, guys, I might not be able to make it for this filming weekend. And Don and Joe was like, ooh, yeah, like the last time we did this. I was like, when was the last time? I checked through the messages, it was 11 months to the day.
So what we've decided is, in 11 months' time, we won't organise a recording weekend because we know that Josh will have dysentery at the time.
100%, yeah.
At least it's predictable.
Yeah, exactly.
At least so far.
That's the best kind of dysentery, I think.
Do you know what I think it is? I think it just goes in the cycles of the NHS when patients start to get
Yeah.
tummy upsets, we'll say.
Approximately a year at a time.
Yeah. Starting to come into winter, autumn months, yeah.
Yeah. I'm feeling better?
Yeah.
Good.
I'm alive.
And we're going for Mexican food later on, so we'll see whether he's fully better.
There'll be blood in the stool, but it's normal.
I feel like it's going to just flush you out. It's going to be great.
Like a howitzer.
Joe, do you want to go next?
Yeah, sure. A fact about me is that my favourite way to eat a mango is to peel it by hand and then just bite at it. So I really like...
How do you peel it by hand?
I didn't like
a
yeah, maybe like I'll cut a
easy
tiny
peel
bit
orange?
off. And then I'll just
you're not allowed a knife.
Okay, if I've not got a knife, I just kind of dig at it with my nails and I'll peel the sides off. And then I just like to kind of attack it with my teeth. I really like to be involved with my mangoes when I eat them. I don't do it in front of other people because it's not very PG, but even though you get the stringy bits in your teeth, that's the only downside, but I like to be heavily involved in eating my mango. And then when you get to the seed in the middle, I like to take my bottom teeth and I like have like I make like an underbite and then like scrape my teeth up it to get the last bits of flesh. It's
Okay, that's quite intimate with mango,
Yeah,
but I
really
think
is.
I might be able to beat you there.
okay.
When I was younger, so obviously I'm Sri Lankan, and so when we go to Sri Lanka,
Obviously.
we'd have...
Yeah, which you can tell, obviously,
From-
listeners.
yes.
It's so clear.
And back home, we had a mango tree. Actually, mangoes, you can get really good mangoes anywhere in Sri Lanka. And so what I really, really enjoyed doing was, as you did as well, the underbite technique, scraping your teeth along the...
I've never heard this underbite technique.
Of the mango.
Wait,
It's
you-
fantastic.
This way?
Yeah, so loads of like...
I do the overbite, actually. I find it easy to do the overbite.
Yeah, fair. But loads of stuff gets stuck to the seed is the problem.
Yeah.
It like clings to the seed, so to get
There's
the last bit
a
of
lot
flesh
of
off, you have
flesh,
to like...
But what I would also do is, because I was obsessed with the texture of this mango seed, I would just play with it in my hand for hours and hours, like a bar of soap, just like twiddling it around in my hand.
Sticky fingers.
Sticky fingers. I was a
Very sticky
child,
fingers.
but I think I would probably still do that.
And then you came and put your hands all over furniture,
Yep.
expensive things,
Yep.
lampshades.
My mum's hair. Yeah.
I've got a story about mangoes.
Go on.
Which is, this dates back
Man,
to
go on.
circa like 1996, 1997.
Okay.
So I'm in primary school. I'm in either reception or like
You're
year
in
one.
infant school,
Yeah.
lower school.
And we had a teacher, she was called Mrs. Freeman.
I was really expecting you to say Mrs. Mango.
No. It's called Mrs. Freeman. She was like, clearly she was a hippie in the 70s.
Okay.
Like she was an old lady, but she told us about, oh yeah, when I lived abroad and what we'd do is, it was gorgeous, we'd eat mangoes and just let the juices run down our naked bodies.
And she said this to like 5-year-old
yeah,
children.
and we was always like, what the fuck is happening?
Mrs. Freeman, go.
This is in an assembly.
I'd love saying this phrase.
What?
In an
What?
assembly, yeah.
Was she the head teacher?
No. She was just like I don't know. She just came to talk to us and do a bit of like
Mango teacher.
Yeah, mango teacher.
And she was fired shortly afterwards for that weird
She was no longer Mrs.
psychotic
Freeman.
break that she had during the assembly.
If anybody wants to picture what she looked like an older version of the teacher from Recess.
Oh, that's
Yeah.
scary. She was scared me a bit.
Yeah.
Even though it's a cartoon.
Is that your fact, or have you got a different one?
Oh, that should have been my fact.
No,
No, I have a different one. I have a lovely, lovely housemate who got me a very early Christmas present. It is currently, as of recording, it is October, late October.
1st of November.
Is it? Okay,
Remember,
then.
remember.
Yes. And he got me a Christmas present for this year. But he really couldn't wait to give it to me. So he gave it to me on, I want to say, early September to mid-September.
It's not a Christmas present.
It's not.
It's just a present.
It was either, September or October. And he was like, I really can't wait to give it to you. But you're going to get a lot of use out of it. I was like, all right, fine. Let's have it. I'm not too precious about Christmas presents. So let's just open it. And it's this. It's a lovely hoodie. And for those of you who don't know what an hoodie is, it's basically a humongous hoodie that's like lined with really, really soft fleece on the inside.
It's like a blanket.
It's
but
a
that you wear.
blanket that you can wear. And it's honestly amazing.
We're going out for food later. I want Don to wear it out.
He looks
Okay.
like a
Not gonna-
medieval era monk right now. If he puts the hood up, he's.
Wait, they
We're
didn't
back
do
to the
that.
mindfulness episode again.
I think he sort of looks like a boxer.
Yeah, it's one of the two.
Can I go?
Do.
Josh, what have you learned about yourself this week?
Well, what I've learned about myself this week is I'm greying very rapidly. I had a haircut today, and I took the first chunk off, and I had a look at the hair. I was like, that's not my hair, and it was 50% grey.
I mean, it'd be weirder if you, while
somebody
cutting your
else's.
hair, sprinkled other people's hair on you. My friend, this part of the service. Like,
It's all right. So I've actually been to the barbers that Josh went to today. And
He's quite angry.
which one did you get?
He was really passive aggressive. The younger guy,
Young,
Younger.
tall, very tall.
very very tall.
Very tall.
He started pressing the thing up, and I was like, I'm going to have a ladder to get down from here.
Yeah, he's all right with me, but I do remember him because I've got very, very thin hair, and it continues to thin every single day. Thin, is that a verb?
Yeah.
Yeah. Every time he goes to cut it, he's like, should I use the clippers or should I use the scissors? Because one will definitely wreck the little hair that you have already, and one will just make me look like I'm doing my job, but I'm not actually cutting anything.
Is it a case of just snipping above your head? And
Yeah.
yeah, it's going really well.
Sprinkling other people's hair to make it look like it's my hair.
Tomorrow you'll get Josh's hair.
When did I go grey? I'm just balding, not grey.
We're all doing well for hair on this podcast.
Joe, what did you learn about yourself?
I learned that, in my opinion, the best home-cooked cuisine is Nigerian food.
Really?
Yep, of anyone's home-cooked food I've ever had, like, I've had home-cooked, like, Indian food, Sri Lankan food, Bangladeshi food. I've had...
Well, I guess Donald just go fuck himself.
had home-cooked Italian food and Spanish food and Portuguese food, all these different cuisines that I've tried over the years. I've never, ever been disappointed by home-cooked Nigerian food. It always blows my mind.
What even is Nigerian food?
Things like jollof rice, things
jollof
like
rice.
fufu, eba, egusi, things like fish stew. Puff puff, the dessert it's like...
It's a dessert?
You want some
Puff puff,
fufu,
the
puff
dessert.
puff?
I thought it was a savoury thing.
No, puff puff is like it's like donuts, like Nigerian donuts.
Oh,
they
what
are
am I thinking of?
unreal.
Right.
My friend does like Oreo puff puff, and I don't usually like Oreos, but it's
I love Oreos.
unreal. Lots of plantain as well.
I don't know how I feel about plantain.
I love it.
How do they make it? Do they just prepare it just fried straight up?
They just season it, fry it. That's it.
Oh, interesting.
Until it's golden
I
brown.
feel like that's just very bland for me.
It was not this stuff.
No?
And often I gather that one of the secrets, according to my Nigerian friend, is to use Maggi seasoning packets.
Oh my God, Maggi
Apparently that is just
is
like a hack for
the
getting
holy
like
grail.
the super
Yeah.
like. I don't really know what the word mouthfeel
Umami.
means, but yeah, umami. That's the
Umami.
word I'm looking for.
Yeah. Do you also enjoy? I've personally never had any Nigerian food, sadly. But Do you also enjoy the communal aspect of it, much like Ethiopian food?
I do. It doesn't feel as communal to me as Ethiopian food, but equally I've only ever had home cooked stuff, so I don't know whether it's being served to me just like it was in like a kind of serve yourself from dishes in the middle, whereas like Ethiopian, when I've had it, I've only had it like twice in my life, but I like the injera, which is like a fermented oat cake that you serve all the food on, and then you kind of just all tear at it and dip in the food in the middle. It was a really nice experience, actually. The best Ethiopian restaurant I've been to is in Manchester, and it is called Habesha, and it is above a, you know, like a shitty end of the night takeaway.
Oh, Happy Chip.
Yeah, like Happy Chip in Newcastle, which thankfully is closed due to, I'm sure, health and safety concerns.
Dysentery.
Dysentery.
When Josh first got dysentery.
Yeah. But it's in the middle of this like shitty takeaway, and sometimes when the shitty takeaway is closed, you still have to go through it. So the way you get to the restaurant is through a spiral steel staircase in the middle of the floor, and you go up to a restaurant upstairs. So like downstairs, it's like the horrible fluorescent lighting and like stinks of like kebab meat and stuff.
Yeah.
Just like old kebab meat as well.
Yeah.
And then you've got this spiral staircase, smells beautiful upstairs. It's like really like nice decor. It's got this lovely like burgundy colour scheme. It's great.
Do they own the place downstairs?
I
as well?
have no fucking idea.
What
If they
the
do,
heck
they
is
should just stick to
happening?
what they're doing upstairs, because downstairs is not good.
That's hilarious. There's just a big fuck you to the downstairs people as you're walking through it.
But it's
to get
weird when you
upstairs.
come in when it's closed. Walking into it's quite like, do you know liminal spaces? Spaces that make you feel uncomfortable. They just don't quite they're like a bit too open, a bit too whatever. Going into a dodgy takeaway that depends on horrible fluorescent lights when there's no lights on, even weirder. Either way, Don, what have you learned about yourself this week?
I've learned that I'm terrible at maintaining the condition of my glass screen protector on my phone. I don't know if you guys are the same. There was a point where I had a cracked glass protector on my phone for, I want to say, a year. And it drove me crazy, but I didn't do anything about it. And then I decided to, because it comes with a spare one in the box, and I was like, okay, let's just put it on. Put that on, within 2 weeks it was cracked again.
Just don't put a screen protector on.
No, because then it's going to be the actual phone screen.
Yeah,
no,
I don't even have a screen protector.
Hear me out, Apple. Sorry. Apple keep making it thinner and fucking thinner. Just make a phone that doesn't break.
Mate, your phone right now is thinner than the newest iPhone.
Well, yeah, because
The screen, though, is
Samsung know
probably
how to
thicker.
do things. How many times have I dropped that phone? Like,
Josh could use his phone
You've
as
got
a
like
hammer.
a heavy-duty military-grade case on it.
It's never broken though.
is it
yeah.
broken? Is
And
this,
that case probably cost him like 15 quid.
not even that. It's
If
the one that
anything, you
had.
should be going for my case because it is the Apple case.
The Apple case, which famously is protecting your phone very well, given all the smashed screen protectors.
And you can see exactly where I've dropped it because it is chipping apart. What? Chipping. Happy chipping. But yeah, I'm really disappointed in myself. This is the third screen protector that I've put on this phone in the last year and 2 months. And no one else does that?
Nope.
No?
No.
Huh.
My stuff just lasts.
Okay.
Mine doesn't. We were doing a filming weekend here months and months ago, and I set up the tripod with the iPad on it, and to get a good enough wide angle, I had to stick it just outside the back door, and then I didn't take into account that the wind would blow over the iPad from a very high tripod and smash it.
Oh, it was grim, wasn't it?
It was. So I claimed on insurance, and then they actually overpaid for how much it was worth.
Don't reveal that.
Because I don't know how they valued it. But then I got a second-hand one from CEX and bought another one. So we only had to pay like 100 quid extra compared to what I got back. And then I have 2 iPads.
Damn.
One for me and one for my wife.
Infinite iPad hack.
One that I don't use, but I do own. And it is with me this weekend, but I don't use it.
I will say though, when that landed, it made such a great sound.
It did. It was.
And it made a beautiful pattern on the shattered screen.
It did, and it still worked. Credit where it's due.
Yeah.
It still did work.
Still work.
It still did work. No, it still did work.
Does did work.
But unfortunately, every time that you touched it, glass did come out into your finger. So,
Well,
but the
that's
bits of
why I
gla-
had to change this as well because I was just finding shards of glass in my bed everywhere.
Oh God, what?
Yeah, because obviously I'd use my phone in bed, and then there was just tiny little shards of glass all over the bed.
You bring someone home after a night out.
Is there glass in your bed?
Are you okay?
Is everything okay at home? Yeah. Either way, shall we get on with the topic of the episode?
Okay, yeah. So as Don mentioned, this episode is on palliative care, and specifically the element of pain in palliative care. And, well, I think we start by, not all people listening to this might know what palliative care is, or they might have their own opinions around what palliative care is. I think it's important that we just sort of set a baseline for what we're talking about when we say palliative care.
Yeah.
So basically, palliative care is the care within the last months or years of somebody's life, which aims to help people to live as well as possible until they die, and subsequently to die with dignity. So I think that's the main thing. It's not about giving treatments with a curative sort of aim. It's about symptom management and quality of life and prioritising what's important for that person.
Exactly, and thinking of what's important to them, it should respect their wishes and preferences to help plan their care, and eventually it should answer questions like where this person would like their life to end. So for some people, they might want to be in a hospital because they want to have access to specific medical care. It might be that they want to die at home with their family. It might be that they want to die at a family friend's house, it might be that's where they spent a lot of their time and that person's been caring for them, so you've got to be respectful of these decisions that people make in those last months of life.
I think we should preface this episode by saying that it can be quite a sensitive topic to discuss. If, you're not particularly comfortable with the concept of death? Yeah. With the idea of death, then maybe, go ahead with caution for this episode.
And obviously, we're hoping that this episode can be very helpful to prepare people in case they or anyone that they love ever has to go through this experience of sort of being under palliative care. But it's also to show you, I think people have this idea that palliative care is the last days of life, and it's this idea of kind of sedating people and giving them loads of pain medication and just kind of almost, I think people get this mistaken idea that it's helping people along the process towards death. It's just kind of making it easier. And it does make it easier, but that's not necessarily what palliative care involves. In fact, yes, it is to do with terminal illness, but it tends to be, we try to target people when they're likely to die within the next 12 months. So you might actually have, I know months don't seem like a long time, but comparatively to what some people might think, palliative care can actually last quite a long time.
Yeah, I've known of patients, because I see them in hospital all the time, that have been on palliative care for over 6 months.
Yeah.
And when people say palliative care, that doesn't mean that we're not treating either. So if somebody gets a chest infection, for example, we're still giving, for the majority of people, we still give antibiotics, we still give those sorts of things. It's just we're not going to do like surgery or anything, sort of like sending you to ICU, that sort of thing.
Yeah.
So, yeah.
And even then, it's important to remember a lot of these palliative patients will be having things like cancer, and often we think about chemotherapy and radiotherapy as curative. We think of them as aiming to cure the disease, but actually they can be used in a symptom management setting as well, which we'll discuss a little bit more later.
Yeah, I've got some good examples for that as well, if you remind me.
So, Josh, going back to the point that you just mentioned, treating patients with whatever they might need at that time, such as the chest infection example. Mm-hmm. When it comes to palliative care, who is it that decides what the course of action is for the patient? How much say does the patient have in their palliative care?
That's a very, very good question, Don, and thank you for asking it. It's a multidisciplinary approach. So the entire MDT, so the multidisciplinary team, help to make the decisions, and particularly in the last 10 to 15 years, there's been a very big push to make it very patient-centred. And not just the patient, but also their families. So it's about what my colleagues in palliative care are very good at is setting expectations about what we can and can't do, what we will and won't be doing, and then sort of seeing what people's expectations are. Like, what do they want? Do they want us to try to prolong their life as long as possible, but with maybe less of a quality of life overall? Or do they want to sort of say, do you know what? Make me comfortable, and we'll see what happens, sort of thing. But yeah, it's very important to get everybody's opinion. So patient first, patient and family's opinions. And what we do is, as well as we put in place what we call ceilings of care. A ceiling of care is the maximum that we would do for a specific patient. So you might have heard of a DNR, or more accurately DNA CPR, which is a do not resuscitate order, where a patient, for example, says, I wouldn't want chest compressions.
Yeah. So say that you've got a patient, for example, who's quite elderly, they're very frail, they've got a lot of sort of comorbidities, and they might have osteoporosis, for example, where, to put it bluntly, if you go jumping up and down on their chest during CPR, if you're applying powerful compressions, their bone health is quite poor anyway, so you're likely to fracture a lot of ribs. They've already got a lot of poor health issues. Their likelihood of recovery is very slim, so it's probably better actually that something like a heart attack or sort of a respiratory failure takes them relatively quickly. I'm not going to say painlessly, but swiftly, rather than them having to suffer the process of attempting to recover from what would be a very traumatic physical process.
Because the thing that I want to highlight here is it's not like, I know we're talking about palliative care, but in this case, I think it's important just to educate people on this. Like, if your heart stops beating, so what we call a cardiac arrest, it's not like the movies. It's not a case of you do a couple of chest compressions and they jump up and they're running about and doing everything they used to do.
You saved my life.
Yeah, exactly. In fact, only 1 in 10 hospital cardiac arrests give spontaneous circulation at the end.
And that's with all the resources available.
So if you're in hospital
disposable,
and somebody sees you have a cardiac arrest, you've got a 1 in 10 chance of surviving with chest compressions.
So then imagine you're in the community, so you don't have those facilities available.
And as Joe mentioned, it's a brutal act. It is, you're putting your body through a lot, and it's not about can we get your heart starting again, it's about the quality of life afterwards. So if your relative who has a very poor functional baseline, as Joe mentioned, has these chest compressions, can we get the heart going again? Maybe, but is it worth it? It's going to take months of intensive care treatment. It's going to take physiotherapy. It's going to be very painful, may require breathing tubes going down the throat. And bringing it back to palliative care, if you have a prognosis of, let's say, a couple of months and then something like this happens, is it in anybody's best interest to bring them back when a case of suffering for months on end?
Yeah. Just speaking of the words best interest, this is kind of a perfect opportunity to bring this in. When we're talking about people making these decisions, like putting a DNA CPR in place, like making decisions about their future healthcare, we discuss something called capacity, which is the sort of mental ability of an individual to perceive information that's given to them, to understand the information, to be able to weigh up the pros and cons of it, retain that information, and make an informed decision. So if you don't tick any of those boxes, if there's any one of those boxes you don't tick, then you're deemed not to have capacity. So you're not able to make choices on your own behalf. And so often people who have maybe cognitive conditions or dementia or something like that in the early stages, while they still have capacity, might nominate someone as their lasting power of attorney. So you can make people lasting power of attorney for health. You can do it for wealth as well. So you might say, actually, I don't want this person to make decisions about my health, but I'd like them to be able to make decisions about my wealth. So if I need care, for example, they can sell my house in order to pay for it. Or they might be your lasting power of attorney for health and wealth, where basically they can make decisions about your treatment when you lack the capacity to do so. So sometimes you'll see people in medical notes where they have a DNA CPR in place, but it was in fact signed on their behalf by their lasting power of attorney because they're no longer able to make that decision for themselves. And that's what's known as a best interest decision.
Yeah, so just expounding on that as well is, like Joe talked about capacity, and you might ask, how do we know if somebody has capacity? How do we know that somebody is able to make a decision, particularly something that's important as this? And when it comes to capacity, there are 4 pillars. The first being the ability to understand. So can that person understand the information that they're receiving? The second is, can they retain that information? So they might be able to understand it and do everything else, but if you come back in 5 minutes and they can't remember what you talked about, they've not been able to fully retain that information. So that's a big pillar. The other one is to communicate. So can they communicate their wishes? And then the fourth one is, can they weigh up that information?
What does that mean, weigh up the information?
So can they think about the pros and cons of their decision?
Okay.
And that doesn't necessarily mean making, in inverted commas, the right decision.
Yeah.
People are allowed to make decisions that go against the best interest if it's informed.
Yeah. So we say in healthcare that people have the right to make an unwise decision. So say, for example, that someone in their last days of life requires additional oxygen, so they have a face mask on, and they have smoked all their life. And our suggestion as healthcare professionals would be, one, don't smoke near an oxygen cylinder because it'll explode. But we would recommend you keep the oxygen on. We'd recommend you focus on keeping your chest as healthy as possible. The smoking will not prolong your life, it will actually shorten it. But if people want to go and have a cigarette and they have capacity, if they want to leave, take the oxygen off, risk the outcomes of that they might go into respiratory failure, for example, then that is a risk that they are completely at liberty to take. And again, I think for people working in palliative care, I've noticed that some of the people I had the pleasure to work with when I was working in community palliative care on a placement was that people have to really be non-judgmental about these things, because people will want to make decisions in the end of their life that seem
clearly illogical.
Exactly.
Yeah.
Exactly.
Yeah, because I can see why the non-judgmental perspective is so important, because as an outsider, watching someone risk their life by doing one of these, opting to do something illogical, such as your example of smoking, could be seen as, one, just crazy, and two, as kind of a waste of resources sometimes. Because say that patient does face those consequences, and then there's more resources in terms of staffing and medications that go into kind of helping them recover. And so I can see why, because you never know why they do the things that they do.
Yeah.
They all have their own reasons, and so it's important to just respect them, because they do have the right to make them.
Exactly. I mean, if you've been smoking for the last 60 years and like the last thing you want to do is just have a nice cigarette.
Yeah.
I said nice cigarette.
But you know what I mean? They feel it's a nice cigarette.
Yeah, exactly. And just talking about all this capacity and these decision making, I think one thing that's really important to sort of put forward is that it's really important to do it as early as possible, when you're as well as possible.
Yeah, it's called advanced care planning.
Exactly. So this is, if you fancy that you're going to be a palliative patient, so you're approaching the end of your life, having these difficult decisions and involving your family and your loved ones and health professionals early is just so much more advantageous.
Yeah,
it's better to do it early when you're still able to, rather than like putting it off until there's a crisis and then the medical team have to make that decision.
Yeah. So take, for example, a condition like motor neuron disease. People might have seen Stephen Hawking was diagnosed with it, but whether he actually had it because he lived for so long is unclear. But you might have heard of Rob Burrow, the rugby player who passed away a couple of years back, who Kevin Sinfield, the former Leeds Rhinos captain, did a lot of fundraising for him and ran marathons, pushing him in a wheelchair and things. Like he's done a marvellous job raising funds for M&D research. But motor neuron disease gradually attacks the nerves which supply all of your muscles, and eventually it will affect things like your ability to swallow, it affects your ability to breathe. And so when it affects people's ability to swallow, they can have something called a PEG, which is basically a tube that allows you to be fed through your stomach directly, so bypassing your need to swallow, because if you can't swallow properly, it risks food and fluid getting into your lungs, which leads to infections and can make a very unpleasant end of life. And so you might want to have a PEG, you might want to prolong your life for as long as possible, or you might think, you know what, when I can no longer eat, when I can no longer enjoy flavours and things like that, actually that for me is so important that I don't want to live any longer. But you can't, by the time that you're making that decision, as well as your swallowing, your speech might have been affected and your facial muscles may have been dramatically affected, so you might actually struggle to communicate whether you would like one or not. So then it becomes best interest decisions, and if that's actually not what you wanted but you can't communicate that, that's quite a traumatic thing. So even though these conversations are difficult, like Josh says, having them as early as possible is the best possible way.
It sounds like there's so much happening when you get that first kind of that first call, that first
Well, hopefully it's not a call. Hopefully it's a sit down and talk. But
but when you're first kind of told about it, and then you need your own time to digest that. But I can't imagine what people go through in these scenarios.
Okay, so then let's kind of bring it back. We talked a lot about sort of decision making in the end of life and how to sort of start facing these very challenging conversations. But bringing it back to pain, it's really important to remember that good pain control is not an endpoint in itself in terms of palliative care. So just achieving good pain control isn't actually good enough really as a palliative care goal. That should be the starting point, and it should be then, on top of that, improving an individual's quality of life should be at the heart of sort of the whole philosophy and practice of palliative care. And so I think it's worth us discussing to start with, why is it that pain is so prevalent in palliative care, and what are some of the potential causes?
Yeah, absolutely.
So research suggests that 70 to 90% of palliative patients live with pain, and 75% of cancer patients in the end-of-life phase will have unrelieved pain. Can someone explain what unrelieved pain is to me?
Yeah, it's pain where we've not given, well, it hasn't been satiated with the medications that we're giving.
So it's untreated?
It's not untreated. We've tried to treat it,
right,
but with all the medications, with all the methods that we've used, we still haven't got on top of it. Whether that's because we haven't explored all the avenues, or whether it's because we have explored all the other avenues and it's still causing a lot of pain. And so if you think 75% of those people in those last days and weeks of life who are living with terminal cancer not getting sufficient pain control, like, this is why discussions about palliative care and research in palliative care is so important, because I think sometimes people think, well, these people are at the end of life, so why does it matter so much?
Oh, could I ask a question? I've always wondered this. Might be a little bit of a sidetrack, but when we discuss pain, particularly when it comes to cancer, can you describe what kind of pain it is? Is it just dull pain? Is it sharp? Or does it vary for whatever?
It's incredibly
condition?
variable. What you got to think about is what's the etiology of it.
Oh, okay.
So by etiology, I mean the cause of it. So cancer itself is just the multiplication of nascent cells. So cells replicating at an alarming rate.
Yeah.
Now, tumours, that's what cancer is, right? It's a tumour, it's a bulk of tissue. Now, what that does is it stops the normal tissue forming its own functions. It can erode into other structures, so for example, eroding into muscle, eroding into glands, eroding into nerves. Now, if anybody, for example, has had an issue with the back, with like sciatica, for example, that's nerve impingement. So that's where the bone's pressing on a nerve, and that's causing that pain. Now, if you imagine you've got a growth inside that's continually pressing on a nerve and getting bigger and causing more pressure, that's one type of pain.
It's also important to note that it doesn't just have to be the cancer itself as well. Like cancer, because it often has a very inflammatory environment around it, causes a lot of inflammation. The swelling itself, even if the tumour itself isn't pressing on it, sometimes the swelling can be really sort of damaging to surrounding tissues. So we'll talk a little bit more later on about how actually swelling management can be a key part of pain management when you're using other medications other than classic painkillers. But it's not just the cancer or the terminal illness itself that can cause pain at the end of life. Actually, treatments themselves can lead to other causes of pain.
Chemotherapy is horrific.
Yeah.
Like, what is chemotherapy? Chemotherapy, people think about it, it's a cure for cancer. What chemotherapy does is it's very good at killing cells. It just so happens, because cancer cells are faster at replicating than normal cells, it kills cancer quicker. So I've known patients that are on chemotherapy that have a lot of nausea and vomiting. One of the potential sequelae of multiple vomiting is like what we call a Mallory-Weiss tear. So that's like tearing a part of your esophagus or your stomach, causes pain. Like the pain of retching.
Yeah.
It's just,
Wow.
Also, you've got to bear in mind as well, nerve cells, neurons, some of them will last from the day you're born till the day you die without replicating. They will just stay there. And so if you imagine that the chemotherapy indiscriminately damages cells, it just happens that it damages faster growing cells first. If it does damage a nerve, that might be a permanent, irreversible damage, and the nerve cell doesn't regenerate. So when you get that kind of, in answer to your question, those sharp, shooting, burning pains, that's often due to nerve damage. Whereas if you've got a tumour in your liver, for example, and it's affecting your liver function and growing and swelling, that might be more of a dull kind of inside ache type pain. But it does vary depending on the individual.
And actually, there's one thing which is always heartbreaking when you see it, which is if a patient comes in with jaundice.
Yeah.
Okay? So let's say you've got a 6-year-old gentleman comes in with jaundice. Jaundice is like the yellowing of the skin, yellowing of the eyes. Yeah. And he's got pain in his abdomen. I'm thinking, thank God. Because it means there's, thank God. I'm so happy that there's pain.
Oh.
The reason being is, if it's pain in your jaundice, it's probably like your gallstone or a gallbladder issue, something like that. If somebody has painless jaundice, for example, it's pancreatic cancer until proven otherwise.
Oh, wow.
Which is in essence, the worst possible type of cancer to get.
It's up there. If I had to choose a cancer not to get, that'd be that.
Yeah.
And the thing is, though, cancer in itself, the symptoms can be so subtle. Like it goes unmissed. Like you're thinking it's a bit of indigestion, so you don't see the doctor. You think, I'll leave it a few weeks. You leave it a few weeks, and you go see the doctor. Then you get some antacids.
Yeah.
It sort of helps a little bit. You leave it another few months, and by that time, it's too late.
Yeah. I know someone whose dad unfortunately passed away from bowel cancer, and he had heartburn for months and didn't go to see a doctor about it. And it turned out that it was as a result of cancer. So it does show you, like, you when you see all these ad campaigns about things like from Breast Cancer Now, for example, the Copper Feel campaign saying to, like, you should feel your breasts, for example, or men, you should feel your testicles. Feeling these, this is funny, I have a friend actually who I met through, like, dance classes, and he says that the first time we ever spoke, I told him that I was a cancer researcher, and I told him that he should feel his balls regularly, which I don't remember telling him, but it's true. Doing simple things like this, people go, oh, it's funny, they're saying, like, to squeeze your balls, whatever. But actually, you know, catching these things early, even if you don't have symptoms, you might actually catch it early enough that you can do something really proactive about it. Whereas if you just ignore it, you ignore that funny looking mole, that lump in your breast, that odd growth that's on your testicle. Like, these things can genuinely be life and death. When you catch them is super important. So,
and particularly with men, we're absolutely terrible as a cohort for going to the doctors.
Yeah. 100%. Coming back to kind of potential treatment-related causes of pain, often in terminal illness we'll use things like opioids, which we obviously think of things being like morphine and codeine and think of them as being great painkillers, and they are, but they also stop your gut from working as effectively, and so you often end up with sort of really quite severe constipation. And actually, similar things can happen with chemotherapy or radiotherapy, where they damage nerves that can kind of control your gut function. And so all of these things can either separately or together increase the risk of an obstruction in your bowel, which, if they are willing to manage it surgically, may require surgery, or if they're not willing to manage it, can be extremely painful and pretty difficult to manage. So this could be another potential cause of pain in the terminal phase of life.
Yeah, and well, we mentioned it a little bit earlier about treatment in palliative care. I think it's a good way just to segue it into here is surgery. So just because somebody's palliative and they're approaching the end of life doesn't mean that they're not candidates for surgery. For example, if somebody has esophageal cancer, so a cancer in the throat that's affecting their food pipe, we might do a palliative surgery where we say, do you know what, actually, if we put a stent in there, that's going to keep, so a stent like a plastic tubing almost.
To keep it open, basically.
Keeps it open, that patient can then eat. And in terms of quality of life-wise,
God, yeah,
it's not going to cure the cancer. It's not going to do anything in terms of prognosis or extending the life. But the difference between able to have a drink, able to eat, is just so much. I think everybody listening to this will agree that that's a good quality of life thing.
Absolutely. And just sort of another thing to mention before we move on from the potential causes of pain, we've got to consider how sort of terminal illness affects people symptom-wise. So you may struggle with reduced mobility. That might be due to cancer in the bones. It might be due to fatigue. It might be due to sort of wasting away, basically, something called cachexia, which is exhaustion based on all of your body's resources being used up. And so you might have people have this reduced mobility, and you might get things like pressure sores, for example, like if you can't reposition yourself in bed, or if you've got issues with incontinence and you end up wetting yourself and not cleaning it up quick enough. All this stuff can impact your skin's integrity, result in sores, even open wounds. And so obviously this is yet another potential cause of pain in the palliative care setting. So it's important that we kind of recognise just how broad the reasons for pain can be. And then that leads us to the question of how do we go about assessing pain in palliative care?
Yeah, so avid listeners of the podcast will know that I keep talking about Greek philosophers, don't I?
You do?
I do, I just love them. And people might remember Socrates, which is one of the ways we learn in med school about how to take a pain history. So that's...
Give me an S.
Sight.
Give me an O.
Onset.
Give me a C.
Characters.
Give me an R.
Radiation.
Give me an A.
Alleviating factors.
Give me a T.
Time.
Give me an E.
Exacerbating features.
And give me an S.
What is the second S? I've already said severity, haven't I?
No.
You said sight.
Severity!
So that basically gives you a summary of all the key questions that as clinicians we want to be asking to people, regardless of the setting where we're asking about their pain. But in palliative care, it is particularly important to understand all of these features so we can understand what the cause of the pain is and also how we can go about treating it.
Yeah, and I think specifically in this setting as well as we might already know all of this sort of Socrates that I mentioned, but it's about changes and about how you're managing it, because people get used to drugs.
Yeah.
And so, like, we may have been treating it really well with oxycodone, for example, but now it's not working as well because your body's getting used to the oxycodone. You need to go back to your doctors. You need to mention it. You need to say, look, the pain's getting worse. We need to do something.
Yeah. And with patients who are still able to communicate, who are still sort of cognitively functioning quite well, we can use things like, you might have heard of numerical rating scales. So can you rate your pain from 0 to 10? 0 is no pain, 10 is the worst you can imagine. A visual analog scale, which is basically a 0 to 10 centimeter ruler, and they say the 10 centimeters is the worst it can be, 0 is the best it can be. Very similar, but basically a visual version. There are some questionnaires like the brief pain inventory, which asks about like the quality of pain. It kind of assesses a lot of the similar things as Socrates. But what's more difficult is when we are assessing people who struggle with communicating, whether that's because they're sedated, whether they're unconscious, whether they have developed communication difficulties with speech, for example. And so what are some of the physical signs that we might look at in these individuals to try and see if they might be having pain?
So blood markers can show us signs of inflammation, for example, CRP.
Cortisol.
Yeah, so physiologically, if somebody's in more pain, their pulse will go up, so the heart rate will increase. We may see spikes in blood pressure as well. These are all sort of your body's sympathetic fight or flight response to pain.
You could also see reduced endorphin levels, altered nerve conduction speeds. Josh, what are nerve conduction speeds?
It's the speed at which a nerve conducts.
Brilliant. Now you know. You can also see increased water and sodium retention, which can lead to swelling, and increased coagulation rates, which can lead to higher likelihood of
thromboemboli. This is the idea that sometimes when you have these highly inflammatory states, your blood starts to clot easier. And so if it clots easier, you're more likely to have things like clots that get into your lungs, clots that get into your veins, clots that get into your brain, causing things like DVT, strokes, pulmonary emboli.
Yeah, so it's a bit like, well, when you've got cancer, you're releasing a lot of proteins into the blood. Proteins that are not normally in the blood, in fact. So what happens is your blood gets thicker, and it makes it so that it can almost coagulate more, like a setting jelly, almost.
Yeah, exactly. And so you've got all these physical things that we can look out for. But it's important not to forget that even in people who are sedated or who have communication difficulties, body language is a massive physical sign that we can use to see pain. Like, for example, you might see someone crying.
Grimacing. It's also important to assess the impact of pain on the patient's life and subsequently on those people around them, their loved ones. Because there might be things that their loved ones are able to discuss that the patient themselves might not want to.
Or going back to what we mentioned earlier about 75% of cancer patients having unrelieved pain. I can speak from a personal point of view from when my father passed away. He didn't want to complain. He didn't want to worry me and my sisters.
Yeah.
So is there some element of wanting to put on a brave face to not sort of make it look like you're doing worse than you are?
Yeah. And that perfectly links with this idea of sort of different psychological, cultural, spiritual factors. They can all impact how a person perceives pain and also how they sort of outwardly demonstrate that pain to their loved ones, like you say, Josh. But equally, what's quite interesting, there's an article from the International Association for the Study of Pain that talks about the impact of culture on pain. And they said this, not me, so I'm not accidentally insulting Italians again. But they said that people from the southern Mediterranean and the Middle East are much more expressive about their pain than other cultures. So if you've got someone who you're caring for who, let's say, is Italian, and I'm saying again, the author of the article said this, not me, they might be more expressive about their pain, so it might be clearer for you when you need to have an intervention about their pain. Whereas if you're someone who's more stoic, like Josh said his father was, and is trying to kind of not worry people around them, not be a burden on healthcare staff, this kind of perception some people get, you might not know they're in pain. Which again, like, it's important to consider that, and it's also, exactly like Josh said, really important to reassess their pain at a regular basis, because if you don't check in with these patients, if you don't ask, they might never tell you.
I have an interesting fact, now they've mentioned cultural differences. And it also, again, it goes back to the Italians. There are differences in the amount of time that a person will pause in a conversation depending on their culture. So cultures such as an Italian, so someone from Italy would pause on average for...
Never.
So someone in a conversation with an Italian would might find it rude because the Italian might interrupt them and not really give them the chance to speak. But this isn't really the case. It's just that they have a much shorter time in which they pause between people speaking. And so if you take, for example, Italians, they'll pause for 0.2 seconds, whereas a culture like the Japanese, they'll pause for a much longer time, like 0.7 seconds.
Like 45 minutes.
Hey.
See, what would be funny there is that then Josh will say another Japanese thing in 45 minutes' time.
And I think it's quite interesting is that we did the episode on language and pain, didn't we?
Yeah.
Did we find that Spanish speakers actually feel more pain?
Yeah, so it seems that when you're thinking in Spanish, if you're bilingual Spanish-English, when you think in Spanish, you have higher pain intensity than when you're thinking in English, which, again, awesome study by Morgan Gianola. Go and listen to Language of Pain Part 2, I think.
Yeah.
Go back and see it. We'll
feel
put,
like we
put a
could-
link in the description.
We will.
I feel like we could do more on that episode. I
we
feel like
could.
there is definitely more to add.
Oh, I mean,
There's
we'll get him
depth.
back on. We'll
Yeah.
get him back on. We can make that one of our annual episodes.
Yeah.
Hint, hint, there's an annual episode coming up. I wonder what it could be. So, dropping the veil a little bit, an editor's note here. The annual episode that we were talking about was, in fact, the 1-year anniversary episode on the history of pain management, part 3. And the order in which we released these episodes got shifted around a little bit. But this episode is going to be cut into 2 parts. We wanted to kind of talk about some of the causes of pain in palliative care and some of the ways in which pain might be assessed in palliative care in this episode. And then we want to look a little bit more in the next episode about how it might be managed and a little bit more about what hospices might do and a little bit about non-medical management as well as medical management of palliative pain. But to finish off this episode, I just wanted to recommend a couple of books for people who, if they or someone that they know are in a palliative stage in their life, these are books that have been incredibly powerful to me and for me while I've been either working with palliative patients or spending time with loved ones themselves in their final sort of days, weeks and months of life. And the first one is Tuesdays with Maury by Mitch Albom, which talks about a college professor who is diagnosed with motor neuron disease, and Mitch Albom, one of his previous students and an author, started spending every Tuesday with him. They hadn't been in contact for about 15 years, and basically this gentleman, Maury, was in his final months of life and was giving key life lessons that he'd learned from being much closer to death. And it's a really valuable read to help you recognise maybe the way in which we can prioritise the wrong things sometimes. And then the second book is When Breath Becomes Air by Paul Calanthe, who was a neurosurgeon who unfortunately developed a very aggressive tumour himself, and he basically wrote the final days of his life and talked about the reflections that it made him have and his treatment and sort of his mindset as he went through it and how it affected his relationships. And if you want to kind of get a picture about some of the challenges that might be faced in a palliative setting and some of the ways in which people can be supported and some of the positives that can be drawn from an awful time, then When Breath Becomes Air is a really important way to do that. And so, yeah, rather than a goodbye from all of us, it's just a goodbye from me as my editor's note here today. But we hope that we will see you again in a fortnight's time for part 2 of this episode on pain in palliative care. Thanks all for listening.